appreciate the interest in this topic, and we did not intend this to be a very large meeting. We intended it to be specific to people who are interested in how congenital heart disease and childhood-onset heart diseases, how they fit within the universal health coverage agenda. And what we would like to share today is a couple of things. First, we wanted to present an example of a successful congenital heart disease program. The example is from the country of Argentina, where they have implemented a national strategy and national policies for congenital heart diseases. And Dr. Martin Sabinoso, who is formerly with the Ministry of Health, will present that. And we also wanted to share a little bit again about the coalition. I believe if you're here today, you're here because you are either a member of the Global Coalition for Pediatric and Congenital Hearts, or you are just someone interested in universal health coverage in childhood-onset heart disease. And we wanted to share about the coalition, that what our current work is and what is our current focus. So Amy, do you mind starting your video? We can, I think, for that purpose, we will have one speaker, which is Amy Verstappen. Amy Verstappen is the founding board member and a founder of the Global Alliance for Rheumatic and Congenital Hearts, an outgoing board chair right now. She is also, alongside with me, co-chairing the coalition for the Global Coalition for Pediatric and Congenital Hearts. So maybe Katie, if you stop sharing, Amy can start sharing her slides.
Actually, Kate, can you continue to share the slides?
Oh, okay.
Kate, sorry. First of all, I want to thank everybody for being here and encourage anyone on this call who is not on our global coalition to join if that's possible for you. Yeah, let's fast forward to my part.
We actually have Dr. Sabinoso with us.
Oh, great. So I'm turning it over to Dr. Sabinoso. Sorry.
Actually, I'll have you start and introduce him. Dr. Sabinoso, welcome. Sorry for the technical difficulties, everyone. Vistra will have you start and introduce him.
Okay, wonderful. Thank you for joining us. Sorry for the technical difficulties. We all thought that we figured this out 5 years after the pandemic started, and we still have issues periodically. So thank you for joining us, and thank you for everyone for the patience. So with us, we have, as I said earlier, Dr. Martin Sabinoso, who is formerly with the Ministry of Health. He is a health systems and health financing expert, and will talk to us about his experience of being the executive director of, the CEO of Plan Nacer, Programa Sumar, which was a program within the Ministry of Health of Argentina. It was an innovative, large-scale, results-based financing health policy, and specifically how within that policy they tackled the challenge of congenital heart disease. Dr. Sabinoso has done a lot of global work, obviously a lot of work with the Ministry of Health in Argentina, where he also was Deputy Minister of Health for a while, and is doing a lot of consulting as well, senior consultant with the Inter-American Development Bank, has done work with them as well as with the working group of the Economic and Health Initiative of the Americas, as well as with the World Bank. So, Dr. Sabinoso, the floor is yours. We look forward to hearing from you about the experience of Argentina. Thank you so much.
Thanks, Vistra. Thanks, Amy and Katie, for inviting me to share my experience, and good morning to everyone. I will share my screen. And well, I assume that you can see my screen now.
You can see it. Yep.
Okay, thanks so much. So yes, the purpose of my intervention is to share my experience, or the experience of my country, Argentina, in terms of how we tried to convert universal coverage into effective coverage in terms of access to CHD treatment. So I will explain some characteristics of our national policy, and I will describe this federal health network that was essential to achieve good results, and some lessons learned that could be of your interest in terms of how to continue make advocacy in favor of UHC for congenital heart diseases. So, well, it is important to understand how our health system in Argentina is structured. It is composed of three sectors: the public sector, the social security, and the private system, that in practice are segmented according to people's incomes. The federal CHD network and Programa Sumar, that was key to improve access to CHD treatment, aims at reinforcing the public system. The Federal Ministry of Health holds the stewardship role. We are a federal country, and the provinces are in charge of ensuring access to their population, and the federation and the provinces interact in this Federal Health Council, trying to align efforts to create consensus on national priorities. And as you can see, the public system is highly decentralized, and it is important to bear in mind that the public system provides free health coverage to the poorest segment of the population. And as you can imagine, there are differences between provinces in terms of budgets, regulations, and results. For us, UHC means making sequenced and gradual improvements in terms of reducing gaps in access and quality for priority services such as CHD. CHD is part of this definition of converting the existing coverage into effective coverage. So as it is complex and it is a long process, we understand UHC as a direction rather than a destination. So what was the situation before the creation of the federal CHD network? Well, between 2002 and 2008, Argentina reduced the infant mortality rate from 16 to 14 per thousand. So the next step was to focus on the so-called hard causes of infant mortality, in particularly to reduce the impact of CHD. So an estimated of 2008 was that 5,000 children were born annually with some congenital heart defect that needed surgery. More or less 46% of this population lacked formal health insurance. So they need to be treated by the public system. And we acknowledged at that time that there were financial and organizational barriers that prevented timely and equitable care for the entire population. In fact, only 8 provinces still today have surgical capacity for CHD, and the absence of coordination mechanisms between provinces caused idle capacity in some provinces and long waiting lists in the city of Buenos Aires. In particular, we were able to see to distinguish this reality in hospitals like the most important pediatric hospital as Garrahan Hospital, but in other high complexity hospitals as well. So in 2008, the National Program for CHD was created at the National Ministry of Health. It was a very important first step towards improving the public response for several reasons, because it brought visibility to CHD as an important cause of infant mortality. We were able to create the first registry of surgical hospitals and the first special budget to finance the surgical operations of more than 1,000 patients was created in order to reduce that waiting list that was identified in 2008. But we needed a long-term solution. So at that moment, the Ministry of Health decided to incorporate CHD coverage into this Plan Nacer, then Programa Sumar, a results-based financing mechanism that I had the privilege to coordinate for several years in order to ensure a sustainable financing mechanism for patients that lack formal health insurance, and at the same time to organize a federal network that expands effective coverage of this pathology. It is important to bear in mind some key testimonies of some of the many champions that this approach have. For example, Dr. Horacio Capelli, that was the former head of cardiology at the Garrahan Hospital, said in 2005, we reported that approximately 1,000 children with CHD were dying in the country without treatment. This was due to publications and complaints that we have already made to previous governments. And we recognized that this was the first government that was receptive to the situation, that understood the problem and called us to implement the plan. And this is very important because the role of experts, top experts in this for this pathology were essential to persuade many key actors in order to develop this new policy to achieve effective UHC for CHD. But what were Argentina's reasons for prioritizing CHD? Well, congenital heart disease, as I said, was the main heart cause of infant mortality. Given that not all provinces have surgical capacity, we needed to create a new coordination mechanisms between provinces in order to defragment the system and to achieve a more equitable access to the whole population. Remember that universal means universal. The lack of equitable access was a highly sensitive issue for the population and for the political decision makers of the provinces. And at the beginning, the opinion of these specialist physicians was fundamental to draw the attention of health authorities in order to prioritize CHD. So, as Ana Esperanza, the former director of maternity and childhood at the Ministry of Health, expressed, we began working in 2004, creating an expert working group combining clinical and management skills, leading to the formal creation of this national plan for CHD in 2008, not 2018, 2008. So the federal CHD network was built through the joint effort of the Maternity and Childhood Department and Plan Nacer and Programa Sumar of the Ministry of Health. So we can identify two main stages. The first stage between 2004 and 2008, well, with the creation of the National CHD Program, with the creation of a nominalized registry for patients, with the categorization of CHD patients on the first explicit waiting lists of CHD, with the development of the initial list of hospitals that had the capacity to perform these surgeries, and with the first special budget line for CHD at the National Ministry of Health. Then the second important stage started in 2009, and with the incorporation of CHD comprehensive care to Plan Nacer coverage, with the acquisition, with the purchase of high complex equipment for surgical hospitals and with neonatal ambulances, with the formalization of the federal network and the creation of the Federal Coordination Center that was critical in order to manage patients from all provinces and to ensure access to all of them, with the development of the first national registry of CHD, with the implementation of a monitoring scheme in order to evaluate hospitals' performance and the effective access to treatment for patients with public coverage. I mentioned Plan Nacer and Programa Sumar. They are the same program. Programa Sumar is the name since 2012 because we expanded the coverage, so we needed a new name for this national policy. It is a financing instrument that links the allocation of resources to provinces and to facilities based on results based on effective access to prioritized services like CHD treatment. So the main purpose of this program that was launched after our worst crisis is to increase effective access to prioritized health services for people without formal health insurance. So this is our definition again of how to make progress towards UHC. And today, this program is covering the whole population with exclusive public coverage, more or less 21 million people. And this program was implemented in a gradual following a gradual modality. We started with 9 provinces, then with the whole country. We started with 80 services, and today the benefit packages finances more than 700 services. We started with preventive services, and then we incorporated high complexity interventions like CHD treatment. And well, today is covering the whole population, 21 million people nationwide. So here you can see this progressive evolution of Programa Sumar and the progressive evolution as well of CHD coverage. In 2008, as I mentioned, the the National Ministry of Health created the specific program. Then in 2010, we incorporated this comprehensive coverage into Programa Sumar coverage. Then as Programa Sumar included new population groups as adolescents, we extended the CHD coverage to adolescents as well. And in 2020, when I was deputy minister, we decided to extend the coverage of Programa Sumar to adults as well. So today there's no limit in terms of age with regards to Programa Sumar coverage. Remember that this program is investing additional resources to progressively reduce these access and quality gaps. And another important and critical milestone was that in 2023, the National Congress passed a national law in order to institutionalize this approach, this national policy, to ensure a greater institutionalization of this mechanism that was very effective, but we needed to ensure some better conditions for its institutionalization. And well, if you want to know more about Plan Nacer and Programa Sumar, here you can find a link to the latest publication. I was one of the authors, and that described the approach of Plan Nacer and Programa Sumar, and the title is Using a Small Lever to Achieve Big Outcomes in a Devolved Health System. And as I was saying, we identified barriers that was a big restriction to the provinces and to the federation to ensure equitable access. So, but we wanted to know more about the main barriers, the obstacles that prevented us to achieve universal coverage. So we conducted a pre-implementation study to assess the surgical capacity. So that included interviews, focus groups, and review of statistics and clinical records in order to identify these restrictions, the potential for growth, and the costs associated with expanding coverage. That was very important because we needed to invest sufficient resources in order to increase access and to achieve sufficient quality of these treatments. And again, let me share one key testimony in this case. I will quote Marcelo Garriga, the leader of the team that carried out the pre-implementation assessment. And he said, during the face-to-face evaluation of the hospitals, focus groups were organized with the entire medical team. The doctors said, it is the first time that we have been asked to give our opinion on how to improve what we do. no one ever asks us anything. So we confirm that people support what they help create. Here you can see this federal network of congenital heart disease. At the center of this strategy, we can identify the Federal Coordination Center. And all provinces have at least one diagnostic hospital that concentrates the list of diagnosed patients. Surgical hospital must comply with very rigorous standards that are defined by and audited by the Ministry of Health, the National Ministry of Health. All diagnosed patients must be reported to this coordination center, and the coordination center refers each patient. Its decisions are mandatory for the provinces and for the participating facilities. And something very important is that the financing system, the financing mechanism of Programa Sumar, encourages compliance with the clinical and the administrative standards of the network. For example, timely reporting, acceptance of referrals, completeness of clinical reports, among other requirements. And finally, shared information systems were critical in order to ensure this patient management system that ensures timely and equitable access to all patients. To improve or to make progress towards effective universal health coverage, we need to understand that we need to create or develop new devices to have greater governance over the facilities, over the performance of provinces. So we created the Referral Coordination Center, and its functions are to assign the surgical hospital, to support patient management, to create and manage the National Registry of CHD, and to audit network performances and results. It is managed by the National Ministry of Health, and this is a new role that the Ministry of Health assumed in order to ensure equitable access, and the referral criteria of this coordination center considers the urgency, the distance, the complexity, and the response capacity of the centers. At the same time, another important innovation was the CHD Network Advisory Board. At the beginning, this advisory board was made up of the top specialists in pediatric cardiology, and its role is to assess the performance of the federal network and formulate recommendations for the program in order to make a continuous improvement approach. And since 2023, with the new national law, this advisory board is also integrated by patient organizations. Two more testimonies of key champions. The first one belongs to Alejandra Villa, the first director of the Referral Coordination Center. She said, between the Coordination Center and Plan Nacer, we gained the trust of the hospital to openly show the particular performances of the hospitals and the network to discuss improvements without it being perceived as a threat or a punishment, but as a serious commitment to improve. So we created confidence in every key actor in order to discuss improvements, to discuss failures, to discuss opportunities to improve, and without the intention to punish them, but with the firm conviction of improving, following a continuous improvement process. The second testimony belongs to Eugenia Olivetti, that is the current director of the Referral Coordination Center, and she said, before the federal network, all cardiologists in the provinces felt very alone with their patients. The coordination center means a great support because you have someone else who is interested in your patients. In Buenos Aires, there could be 500 doctors around the patient. In many provinces, there is often only one physician with his or her patient. Here you can see the pillars and the enablers of the federal network of CHD. One key pillar was this National Equity Fund. The second was was the collaborative intergovernmental governance, working in provinces and the federation working together, and committed to achieve a common result with a common vision of the strategy. The federal care network managed by the Referral Coordination Center. And finally, the combination of political, clinical, managerial, and citizen leadership through these patient organizations that are critical to develop and sustain this national policy as a priority for the federation and the provinces. And there are some other enablers to make this happen. For example, shared information systems, strategic financing of these services, comprehensive training programs, healthcare standards and procedures, among others. This patient association, named Latidos Diferentes, different heartbeats, played a fundamental role to pass this national law for CHD. And as I said, this new law regulates all the components of the national strategy. It was easy to define the content of this and to reach some consensus on the content of this law because of the well-designed and implementation of this national policy. So in some way, we decided, with the support of the legislators, to transfer all our regulation of the Ministry of Health, of the program, and some other new refinements to the content of this national law, and the support, the active role of this patient association was key to convince and persuade legislators. And you can see here that they are saying our law is ley, it is a law, it is our law. And one of her members, its members said, as a group, we are just groups of families and friends. We became part of the advisory councils of each province and begin to ensure a true implementation of the law in every corner of the country. Once again, the struggle of hundreds of mothers and families reached the Senate and bore fruit. So this is something very important to consider, because this patient leadership is critical in order to make progress with CHD universal coverage. And here you can see more information about this association, Latidos Diferentes, different heartbeats. I said we developed as a key pillar a new financing strategy. We created the National Equity Fund that finances 100% of this intervention. The value of the per capita that is transferred to provinces and facilities is defined by regular costing studies. This is a very good practice in order to ensure sufficient resources. And its coverage then was extended to other interventions. We started with CHD, but then we included acute myocardial infarction, intensive neonatal services, and with the pandemic, the hospitalization of patients that were suffering COVID-19. One of the enablers was to develop a performance-based management approach. So we developed different instruments in order to monitor the performance of participating hospitals. Here you can see the scoring for the evaluation of surgical hospital performance that has 4 dimensions. Well, for example, the contribution to the federal network, the quality of care, patient satisfaction, and surgical outcomes, for example. This information, this assessment, are permanently analyzed jointly by the Ministry of Health and now the advisory board in order to improve, to detect weaknesses, and to develop more effective action plans. Here you can see that we are also monitoring not only the performance of surgical hospitals, but the performance of diagnostic hospitals as well. For example, we are measuring the diagnostic accuracy, that is to say, the diagnostic correlation between diagnosis of the report to the referral coordination center and the diagnosis made by surgical hospitals. And the same, a set of performance indicators to complement our assessment of surgical hospitals is also essential. For example, to verify if hospitals are accepting the referral decisions of the coordination center, because as I mentioned, its decisions are mandatory for facilities. Some results. I am now working on the last slides. Some results of the CHD network. Well, the number of people diagnosed increased between 2011 and 2016, 66%. The number of surgeries increased by 63%. The number of patients on waiting list diminished by 86%. In 2017, we confirmed that it was possible to achieve all these results through regionalization. Only 1% of patients underwent surgery outside the intended regionalization scheme. And in terms of measuring the satisfaction of patients, well, in 2013, we confirmed that 98% of users rated the service at diagnostic centers as very good or good, and 97% reported the same rating for surgical hospitals. This is the evolution of number of patients diagnosed and that received intervention. So here you can see that we were able to develop this national registry for CHD, collecting real-time information of cases being diagnosed and treated nationwide. Here it is very interesting because as I mentioned at the beginning, it's not only about investing additional resources. Sometimes we need to organize better organize the resources, financial resources, human resources that we have to make an impact, to ensure more access to more people. And here you can see the impact of the intervention of the Referral Coordination Center. So thanks to its intervention, for example, the Hospital Garraham, one of the hospitals with the higher complexity, was able to increase the number of highly complex surgeries according to their accreditation. In 2008, before the program, 40% of its surgeries, interventions, were of low or medium complexity that can be treated in the provinces, in other provinces. But this hospital has the higher complexity, so it must focus its role on the highly complex surgeries. And we were able to improve this because in 2011, 1 year after this federal network, this hospital reached this percentage of 87% of the surgeries were of higher complexity. So here you can see the importance of having these governance devices in order to support and help facilities to play its specific role within a national strategy. And what are the distinctive characteristics of the CHD care strategy in Argentina? Well, the active role played by top experts, physicians, the scientific society, and patient associations to develop and improve the national policy. This collaborative approach across level of governments, a systemic approach through which several essential functions of the health system that are simultaneously improved, the national law that we passed, and these quality assurance and monitoring and evaluation mechanisms that we deployed in order to assess the effectiveness of the national policy. What are the pending challenges? Well, there are still disparity in performance between provinces in terms of how they are managing local networks for diagnosis and follow-up of CHD patients. We need to develop the new generation of specialized professionals. We need to improve the quality of patient transportation, particularly from distant provinces. Uh, Patients with formal health insurance are off the radar of this federal network. Remember that this approach places the focus on the public system for people without formal health insurance. And of course, there's an ever-present challenge that is we need to maintain the commitment of all participating actors to comply with the rules of the federal networks. Sometimes some provinces take advantage of the benefits, but do not sufficiently assume their responsibilities. So in this regard, the advisory board with the participation of patient association is very important to ensure this permanent commitment with
You seem to have lost Dr. Sabinioso. Let's see, give it a couple more seconds. This is his last slide, so at least. All right. Maybe we can continue on to Amy Verstappen's part of the presentation. Yeah, we lost him for a second. Amy, do you mind coming on video? And then Katie, please share Amy's slides, and Dr. Sabinioso will come back. This was really his last slide, so we didn't miss much. Hopefully he'll come back and we'll be able to ask him questions. So Amy will talk brief overview of what the Global Coalition for Pediatric and Congenital Hearts is doing right now and what our goal is, and then we'll go into question and answer. Go ahead, Amy.
Thank you so much, Bistra. I'm very pleased to be here today. And as many of you know, if you've been a part of the Global Coalition thus far, our goal is right now to achieve a 2026 World Health Assembly resolution on pediatric and congenital heart disease and care. Next slide, please. One of the things that struck me about Dr. Sabinioso's presentation is when they started out their campaign, they started with some published papers and essentially making a case. And we're very excited that we have developed and now have published new resources for members of the coalition and public as well to help us make the case for why this is important. So this is a longer case statement, which is this invisible child, take action to change the future. And then also a shorter summary, essentially, of the key data points and key action points from that case. Next slide. So what's our timeline? So at the highest level, right now, we're in the stage of engaging member states to table the resolution. So briefly, the way this process works is when a coalition like ours has an idea, you need to get member states of WHO to take responsibility for kind of taking the lead and bringing it officially to the WHO. And that's what stage we're at right now, is identifying those leader states. Then after you get your leader states, you begin the actual drafting and negotiation, and then you submit it to the World Health Organization Executive Board for consideration at the next meeting. They ideally accept it, and then what we're hoping for is in May of 2026, so a year from May, all the member states will vote to adopt the resolution. And when that happens, that means that the WHO will, and the member states will agree to specific action to address this issue. Next slide, please. So just briefly, the kind of strategy we have been taking is to identify which countries will serve as the champions is some mapping. So looking at all the country mapping and starting initial outreach. So the World Health Organization, as I mentioned, has an executive board. So we decided to prioritize the countries who have a seat on that board and will continue to have a seat in 2026. We also, because these are the two organizations who are leading the coalition, started with, okay, where does the Global Alliance for Rheumatic and Congenital Heart have organizations that are engaged already with their health ministry? And then also, where are locations where Children's Heart Link has engaged with the health ministry and has an existing relationship based on the program work they do in that country? So thus far, we've started having outreach and meetings to assess their interest in championing our resolution. We've had initial discussions with Australia, and we're following up. We've been following up to engage the patient organizations, including New Zealand and Fiji, and we will be having a second meeting soon. In Bulgaria, which we've had a sort of long-standing relationship with the patient organizations, Bistra was able to meet with them in November in New York, and we will be following up. In Chile, there has been really effective engagement in Chile with the health ministry thus far. In Malaysia, we've had meetings in September and November. And finally, in Namibia, we did meet in May at the World Health Assembly along with the meeting we had a World Health Assembly side issue, but we were able to meet with Namibia and then met again in November. There's lots of different countries we're thinking about. They're listed at the bottom, but this is one of the things that you all can help us with as we continue. Next slide, please. So that's the heart of what I want to talk about here. So first of all, I have outlined the very high-level goals of this coalition, but we're going to have a lot of smaller achievements along the way, and a lot of that is based on the work that you all can do, both you're probably already doing and what you can do to achieve awareness and action. So I know that many of the organizations and many of the individuals on this call actually engage in just raising awareness of childhood-onset heart disease. And this is the foundation of this work. This is the most important things in some ways for setting the stage for the resolution and action in your own country. The second stage in some ways is connecting with your government and your health ministry. And I want to call out that Global Arch and Children's Heart Link together designed a very concrete advocacy toolkit. So for many organizations and people, if you're taking this on, the first question may be, well, how do I even do that? Or how do I cultivate that relationship? This gives some very concrete advice. So for example, one of the very basic ways is just inviting somebody from your government or health ministry to come to an event or an activity you have, invite them to speak and start that. That seems small, but it's a very important step. And then as Dr. Sabagnosa highlighted, and this is in some ways a fundamental goal of this coalition, really cultivating a relationship with the patient organizations and with patients and families in your area. So we believe, and we saw this in Dr. Sabagnosa's presentation, that coalition between the patients and the providers can really drive the action, including legislative action, which underlies this. We want to highlight that your local advocacy, both specifically speaking out for the resolution and also creating successful models like Dr. Sabagnosa's model in your own country, is essential. And finally, we would really like to be available to help those who are interested continue to develop this advocacy, specifically to engage with more health ministries. And also, I want to note that I see many people on this call who are not actively engaged in Global Arch or the coalition right now. One very concrete thing is if you need help identifying a patient organization in your area, or you don't have one, this is also something we can assist with. Next slide, please.
Thank you, Amy.
Thank you. So I want to turn to, oh, I'm sorry, Bistra, do you want to go on?
Yeah. No, I think we're getting close to answering people's questions. We have quite a few questions already asked, and so I want to give an opportunity to Martin to respond to those. But I also want to reiterate what Amy just said about the Global Coalition for Pediatric and Congenital Hearts. We have a goal, we're working towards it, we have tools. Please contact us if you want to get more engaged. So we have a number of questions, and maybe we can start with the first one, which comes from Leonardo Miana, who is from Brazil. And his question is about performance data, and does the performance data become public, and how do people know that they're doing a good job with the outcomes of their surgeries?
Thanks, Bistra, and apologies for my interruption. It was a problem with the internet connection, so I am back. Well, this information about the performance of each public hospital is not public. What is public are the global results, the national results in terms of how we are improving the diagnosis, timely diagnosis, and how we are improving the number of interventions, timely interventions that the national network is achieving. And of course, how additional money we are investing. And there was a question about the source of this equity fund. And I can say today that we have three financing sources. The National Equity Fund that is managed and financed by the National Ministry of Health has two sources. Public resources from the national public budget, and part of its resources are coming from a loan from the World Bank. The World Bank played a strategic role as well, because it was a key ally in terms of helping the country to inject additional resources, but also in terms of the technical assistance that we received from some experts, global experts, that helped us to shape this intervention. But at the same time, since a while, provinces are co-financing this CHD network. For example, low and medium surgeries are co-financed between the national government and each province. So we are trying also to sustain, institutionalize the network, the national policy, with the financial effort of each jurisdiction.
Great. And I think that's very important what you just said, because it shows that it's not a simple, just here's one pot of money and go ahead and do it. It's a combination of things that came from the loan, came from provincial budgets, and came from the national budget. Yeah,
exactly.
There's another question about the costs of the program. What was the operating budget when it was started, and what is it now? I'm not sure if you have that information.
I don't have that information, but it's in terms of the national budget of the National Ministry of Health is almost nothing. Almost nothing. You can see, for example, I have one figure. For example, the total approach of Programa Sumar that includes CHD treatment plus this long list of 700 services that are part of the benefit package represents less than 1% of the total national budget of for health. And this represents a small share of that small budget of that represents Programa Sumar in terms of the whole budget of the Ministry of Health. So it is an incremental approach. This is something very important because through this intervention, we were able to improve the functioning of the system with the existing resources. As I said, there was idle capacity in some provinces, for example, in the south or in the north, but we had long waiting lists at the city of Buenos Aires. So with the intervention, with this national agreement between the federation and each province, and with the intervention of this coordinating role of the coordination center, we were able to make a better and more equitable distribution of patients. So these 16 countries that these 16 public hospitals that are able to make these interventions, they all increase their production because of the resources and because of the coordination.
Yeah.
So as I always say, it is not only about investing more money. It's about investing more money, trying to align the money to the objectives. We need to distinguish between means and objectives, and sometimes we can improve and be more effective and efficient if we create these new devices that help provinces and hospitals and physicians to perform better their specific and complementary role.
Amy, I want to give you a chance to ask a question if you have any. If not, we can continue through the list here.
I don't think I have any questions. I do want to highlight that this issue of transparency of data is very central to patients and families. I see that the person who asked the question referenced transparency in the US. I'm in the US. I can tell you that the data actually is not public facing, or at least it only recently started to be publicly facing. And the public facing of it was due to patient family efforts. And this is the question of how do we use this data to inform decision making is we hope that as many of the countries develop these programs, that is built into the system.
Yeah. One question is, what strategies have kept the government engaged? Do data and proven changes play a key role? So what has motivated the government to continue to engage?
Well, yes, it's a very important question. And as I mentioned, we are talking about the main hard cause of infant mortality. Then the role at the beginning of these physicians, well-reputed physicians, was also very important to persuade political authorities. And the main message was, we have a problem, a big problem. There's a clear inequity with CHD, but it is possible to improve access and to save more lives by making a better use of available human and financial resources. Of course, it's always better to invest additional resources, but it is possible to improve with better organization in order to take advantage of the existing resources. 3, the collective voice of specialists and patients through these patient organizations is very powerful. So if you can join and work together and create this shared message, shared vision, and collective voice, you will have more opportunities in order to persuade everybody. Again, there is increasing more clinical experience and more knowledge in how to better treat congenital heart disease more effectively. So through these interventions, you can reach real impact in terms of UHC. And this is a very sensitive topic, CHD, for the public opinion and for the media as well. So I can assure you that Plan Nacer and Programa Sumar made several contributions in 20 years. But the most important recognition that the program permanently received is its contribution to the federal network of CHD. It is the more visible, more tangible achievement of Programa Sumar. So
Yeah,
there
that's very
you
important.
find a big opportunity. Oh,
Yeah.
sorry, Bistra.
No, I was going to say that's very important because I think there's this perception that this service is expensive, we shouldn't invest in it. How much is going to cost? I think it shows in the questions that you're receiving. Is it expensive? What was your budget? And I think what you're saying is the costs are not everything. The costs are not as high as people think they are. And the program is actually more important than people think it can be. So we are almost not appreciating how important it can be and how much visibility it can bring to the government that is implementing it.
Exactly. And at the same time, we always need to consider the cost of not investing in these health problems. But I can also assure you that the CHD network become like an inspiring story and an eye-opening approach to everybody, to the federation, the provinces, the political authorities, to patients, on how to move towards UHC. So we developed like a sort of recipe that, of course, we need to adapt to new objectives, to different objectives, but now we have a clear understanding on what means effective UHC and how to apply these learnings to address other important problems in terms of health access and quality.
Yeah. One question we did not answer, and the question was, and I think we'll close after that because we're at the hour. How many pediatric cardiac surgeons are in Argentina currently, 10 years versus 10 years ago? Do you know that number?
Yes.
In the public sector.
In the public sector, yes. Of course, we have more surgeons at the public sector because the public sector is functioning well and it is a better place to work and to realize or to achieve your vocation, to deploy your vocation. And for example, I can give you an example. The public hospital of the province of Corrientes, that is like the referral hospital for the Northeast region, 10 years ago had only one surgeon. Today, this hospital have 3 surgeons. And that was because it became the regional hospital, not only for the citizens of the province of Corrientes, but for the citizens of 5 provinces in the Northeast region. And because of the sustained support of the national government and because of the sustained rules of this new approach. So when you give a strong signal to the system that you are going to prioritize in the long term one or each pathology, the system react positively with a sustained commitment as well.
Wonderful. I think this is a great statement to close this webinar on. That I think giving a strong signal of what we're trying to achieve, it actually, that's what our advocacy is about. Amy, do you want to say the last few words?
No, just to thank Dr. Samaniego with a really excellent presentation and information, and also for achieving what you have. in Argentina, and encourage all of you on the call. I see a lot of great questions that we can't engage with yet, but please reach out if you would like to have more engagement in our advocacy. And thank you so much to everyone for coming.
And more conversations on this topic. Yes, we're looking forward to hearing from everyone. Thank you so much, Martin. Thank you, Amy. And we're going to
Thank
close
you.
it now. Thank you.
My big pleasure. And congratulations
bye-bye.
for your work.
Thank you so much. Bye-bye.
Bye bye.